The agenda this week examined the gender pay gap among physicians in Ontario, learned what role internationally educated nurses could play in our healthcare system, and looked into whether COVID-19 was leading to a baby bust in Canada. The Agenda's Week in Review begins by finding out the latest on what's called long COVID.
In the year since you were last with us, what do you know now about long haulers, as they're called, that you didn't know a year ago?
We are learning a lot in terms of what is causing these long haul symptoms. We have some top hypotheses for why people are having these symptoms. Probably the top one is vascular endothelial dysfunction, which means there's a damage to the lining of the blood vessels, and it affects how blood is delivered to various systems. And the second hypothesis is immune dysregulation. So there's a change in the way that our immune system is working, and it may not behaving in the usual way. And then the last hypothesis is really around residual viral particles or residual virus hiding. And those three are the top hypotheses right now.
Okay.
And there are studies supporting all of these hypotheses.
And let me get you to follow up on that in this regard. Of the total universe of people that get COVID-19 at all, what percentage of them are long haulers?
You know, it's very difficult to estimate, but I think it's between 10 and 50%. So the lower estimate is 10%, which means, like in Canada, we have more than 3 million people who have had COVID. And so 10% would be 300,000 people. And it may be as high as even close to 1 million. The problem is the definition of long COVID. Do you count people who only have one symptom, like loss of smell and taste, and they're not quite back to normal? Or do you only count those who can't go to work and still have debilitating symptoms and can't do the activities of daily living? And so I think, it's the severity of it that makes a difference in terms of the percentage.
And Dr. Banerjee, let me try this with you. Just as with regular COVID-19, if you're a young person, a teenager, the impact of getting COVID-19 is likely to be a lot less than if you're an older person. Is it the same with long COVID?
So we don't really know how many kids have had COVID to begin with. So we don't have a denominator because kids with mild symptoms don't get screened, and sometimes the test can be falsely negative. And again, we have different definitions of what is long COVID. But if you look at the studies, it's between 2 and 50% of kids that have a positive test for COVID that end up having long symptoms. So there's we think in general most kids don't get too sick, but there's a small percentage of kids that have debilitating ongoing symptoms.
And I'll follow up with you with this. Would the symptoms, if you're a younger person and you're a long hauler, be the same as if you're an adult?
I think that there are less kids that have symptoms, but the symptoms are similar with the brain fog, the muscle ache, the shortness of breath. But also it depends on, like for adults, they have more comorbidities. They have higher rates of diabetes and things like that. So there may be more impact. But I've seen children, more teenagers than younger kids, that have quite debilitating symptoms, similar to adults.
Dr. Chelios, what's the longest amount of time you've heard of somebody living with long COVID?
I've seen patients actually with symptoms persisting more than 15 to 16 months. I don't know about 2 years, most likely. We had the first cases in Canada, if I'm not mistaken, in February 2020. So I guess we need some time for this. But what I'm saying, Mr. Bacon, in general, because I'm taking care of patients with long COVID here in Hamilton at the St. Joseph's Hospital, is that some of the symptoms may get better with time. For example, fatigue or in this difficulty breathing, some of them feel better with time. In some symptoms like the anxiety, the depression, the non-restorative sleep these people experience is not getting better, at least after 6 months from the start of their follow-up. So we see that this is an issue to these people, and this creates not only anxiety but disability, but the disability when it comes to work. Some of these patients are still on short-term disability, and I'm afraid that we'll need to consider this in the future.
Women and men have been graduating from medical school at about the same rate for 2 decades. There are going to be more women doctors in this country than men by the end of this decade. And yet women are really far behind in terms of the leadership pipeline.
Well, we have one of them here, and I'd like to know what she thinks at the beginning of what you hope, I presume, will be a long career in the medical field. What do you think, Dr. Dosa, when you see these numbers?
Yeah, I mean, I think it reflects the lived experience that I see as I go through my medical training. Often we hear the argument that this is just a pipeline issue and things will get better over time. But if we reflect on the specialties that are already predominantly women, we see that that's not actually what's happening. I think if we look at obstetrics and gynecology, it's a great example of that. Predominantly women are in the majority and have been for a very long time. But even within that specialty, if you look at who's occupying the leadership positions throughout the country, it's still heavily, heavily dominated by men. So I don't think it's necessarily a pipeline issue. I don't think that we can just assume that things are going to get better on their own over time.
Well, let me make this assumption. My assumption is that the people watching or listening to this suspect that you and your male counterparts earn the same. Do you?
I'd love to say that women in medicine and in surgery, which is what I practice, make the same amount as their male counterparts. Unfortunately, we have evidence that that's not the case. We've studied that specific question here in Ontario, where physicians are primarily paid on a fee-for-service basis, meaning you get paid for the procedures that you do in surgery. And it sounds like, in theory, it should be an equitable system. And unfortunately, we've shown here in Ontario, female surgeons make about 25% less than their male counterparts.
Now, how is that possible? If you're both paid the same amount for the same service, how can you be making so much less?
Yeah, obviously, if we're doing the same service, we get paid the same amount. So really, the mechanism behind this is the idea that we're not doing the same service, that for whatever reason, women are more often doing the less lucrative procedures in surgery and probably practicing that way throughout medicine, not just in surgery. Our data show that the more remunerative a procedure becomes, the fewer and fewer women you see doing that procedure. And I don't think that's a coincidence. I don't think women are choosing to do the procedures that make or provide less income. We have to believe that there is some kind of systemic bias that's driving this.
Okay, here's our systemic bias expert now, Sarah Kaplan, who we bring into the conversation. Do we assume, Sarah Kaplan, that for whatever reason, the province of Ontario and or the Ontario Medical Association, which after all negotiates these fees, do we assume that they are putting a greater importance on the procedures mostly done by men as opposed to by women? Is that what's happening?
I think that's a really interesting hypothesis, and one that it could be true that because of the historical leadership gap that Robin already pointed out, that the people who are in power, who are negotiating these rates, are negotiating rates for the procedures that they do. I think the other reason, though, really has to do much more with referrals. So, for example, in surgery, surgeons don't do procedures without being referred a patient from another doctor. And often those referrals are biased. There's plenty of research to show that, in fact, women are getting referrals for the lower remunerating procedures than men are. And so that accumulates over time, because if you're not getting the referral to do the procedure that pays more, you're not going to be able to do that procedure.
Dr. Dosa, I presume you are a member of the Ontario Medical Association now. Do you think they know about this issue that we've just identified?
Yes, I think they do. I think they've published their own research corroborating all of this, showing that there is a gender pay gap across all medical specialties in the province. And I think they do now know that some of this is rooted in referral bias. We recently did a study, our group here, showing that that was certainly driving a fair amount of the gender pay gap. So the data are out there, and now it's just a matter of trying to address them and find solutions to this issue.
Well, that's the question, isn't it? Do you think they're adequately seized of this issue to want to do something about it?
Yes, I think, in fact, the time is now. I think that all the data are out there. If there is going to be change, this is the time. And I actually think that the pandemic opens up a window of opportunity. We've seen through the pandemic a number of ways in which our healthcare system has deficiencies. And it really gives us the opportunity to try and address numerous issues, those being to provide better, more timely and equitable care for patients, but also how to restructure our healthcare system to make sure physicians are treated equitably as well.
Sarah, let's hit on one really quite fascinating finding here, which is that health outcomes and success rates of procedures, the system measures this stuff. And they measure it when these procedures are done by male as opposed to female surgeons and or doctors. What have we learned about the outcomes depending on gender?
The research has shown that when women have an operation from a surgeon who is male, they are 15% more likely to have negative outcomes and 32% more likely to die than if their surgeon is a woman. And that difference doesn't exist for male patients. So there's no difference between a female and a male surgeon for a male patient. So this is the kind of evidence that's suggesting that, these biases, the lack of access to these professions is creating real health inequities.
Let me ask every Canadian nurse out there how they will feel if they were to go to another country and be told that the only way they can transition to practice is to work in another area, like, for example, as a personal support worker. How would it feel for you? And to bring your credential, your Canadian credential, which you believe right now is so valuable and so, highly esteemed, and then they tell you that it's not enough because we have a process. Yes, we have standards. We have to meet those standards, high quality care and education. However, I think a lot of this has to do with discrimination.
Amina, I see your head. You're nodding a lot, so I can assume that you are agreeing with Birgit a lot on this. I'm curious, obviously, you and Carla have firsthand experience. What are some of the barriers faced by internationally educated nurses when they get here?
I think, first of all, is the lack of clarity in the process. Once you send your credentials to be evaluated and you receive the report and send that to CNO, the response you receive, they are not clear how to address those gaps. So, for example, in my case, my biggest gap was the educational one because my education was not evaluated equivalent to the Canadian one. And now, how do I do to fill those gaps? So they're not really clear orientations. They say it is your responsibility to find the program. And after you complete the program, they're going to evaluate if that is enough or not. So then I need to go there, find the program myself, complete the program, pay for that. So just after that, I can receive a response if that would be equivalent or not. And also another thing that I also think it is huge, it is the delays in the process. So as I said, I send different types of documentations to CNO to try to somehow address those gaps. And they had some response that took over a year to receive back. And then you receive those responses and they did not accept that. So now you need to start everything from the scratch again. So I think it should be more clarity in the process for sure.
Carla, I want to get you in on this. It seems like you've done your due diligence. You've gone back, you've done all your tests, you've done everything. What are your thoughts in terms of the barriers there, for someone who's still waiting?
Well, the barriers, first and foremost, is it's very costly. For caregivers, there are 300 internationally educated nurses who are working as caregivers. So for them, some of them are helping out their families. So the salary that they receive should be divided between sending money to their families and also with the registration. So it's quite hard for them because every examination is expensive. You have to take the NCLEX, you have to take the IELTS, the documentations, you have to call your school for them to submit all the documentations needed by the assessment, the people assessing with the College of Nurses of Ontario, it's quite hard. Another is that, like I said, it's you are working full time. Some of them are even working very long hours. They do not have enough time to study, so it's quite hard for people like me to balance the time between studying, between working on the documentation, between working as a caregiver.
I want to pull up a tweet that Birgit once tweeted. You know who isn't done with COVID? Nurses. We are tired of people who don't care about how their actions affect the vulnerable, immune compromised, disabled, and marginalized amongst us. We are tired of being called heroes. We are so tired of everyone who's done with COVID. Hero. It's a bit of a triggering word. Why?
Why do we have to be called heroes? If not that they've made the working conditions so bad and they're shocked that we're able to thrive despite the poor working conditions. And not only that, like the same government that calls us heroes has put in a legislation to cap our wages. Like, what a slap in the face. Like, with the one hand, you say, hey, heroes, and with the other hand, well, you can bargain your pay. No matter the increase in workload, I do not care. You know what? I'm going to keep providing you hospital beds. I'm going to keep, trying to find you, non-qualified, non-nursing staff to come and assist you, despite being short. So yes, every time I hear that word heroes, I am triggered, and not just me, my colleagues are too, because the working conditions are so bad, I can't even tell you.
Is it possible we could have a baby boom when COVID finally becomes endemic?
Well, there might be a little boomlet, but I think the long-term trend is in the other direction. I know that StatsCan has decided that we are among the lowest of the low in terms of fertility countries. No, they ain't seen nothing yet. South Korea has dropped below 1. Countries like Japan and Taiwan and Singapore, they are all crashing down to 1 or below 1, or very close to 1. 1 full baby short of replacement rate. And they are going to lose substantial portions of their population over the course of this century. China will lose up to half of its population over the course of this century. The same phenomenon is underway in parts of Eastern Europe as well. It is reasonable to assume that Canada will mimic everyone else, and that our population will continue, our total fertility rate will continue to decline to somewhere around 1. No one yet has actually seen what the absolute bottom of this trajectory is.
Laura, how about this? And I don't want to indulge in too many stereotypes here, but I will just for argument's sake a little bit. You know what they say about this generation of childbearing people, right? That they're all extremely individual and, just very, very interested in what utterly unique people they are in the world. Has that kind of sense of individuality contributed to the fact that they don't want to have as many kids as their parents or grandparents?
Oh, I think that's a big question. That's a loaded question. I think sort of this, we've seen this historical trend towards, lower fertility. We call it like the demographic transition, that is argued to be partly driven by this like push towards individualization, individual happiness, the pursuit of your freedoms and what makes you happy, versus sort of like those traditional ideas about, supporting your family and sort of these responsibilities, these religious or familial responsibilities. So I don't think it's any specific generation that is, particularly individualistic. I think the bigger issues are sort of the structural constraints that the childbearing population is dealing with right now. It's the unaffordable housing. It's economic uncertainty. Job losses, stagnant wages, inflation. It's that children cost money, cost a lot of money, and that. It really does take a village to raise children. And I think sort of the other implications of this aging population is that you used to think about a family tree and you had like all of these branches coming off of your tree, but with fewer and fewer babies born per generation, our families are looking much more like a beanpole. So we have many generations alive at a time, but few people within each of those generations, which means these sorts of family support systems, family care systems, grandparents taking care of grandkids, or adult children taking care of their aging parents, there's fewer people to draw on. So I don't think it's about selfishness, about self-fulfilling and some sort of pursuit of happiness in a hedonistic sense. I think it's trying to balance all of these really competing, challenging structural systems that make having babies and having large families really difficult.
Gotcha. Well, I did say I was indulging in stereotyping there just for effect. But anyway, down to our last couple of minutes here. And Tally, let me ask you about this. Most people I talk to who have children say it's the greatest thing they've ever done in their lives. It has brought such joy and yes, of course, heartbreak and difficulties and all that. But at the end of the day, it's the most meaningful thing they will ever do. Are you really telling us that there are patients of yours that say, the price of housing is too big these days, and therefore I'm going to forego that profound experience? Really?
Well, what I'm hearing more is, in my practice at least, my patients who have had a child or two and maybe thought they would have 3 or maybe even 4, after experiencing the hardship of the last 2 years, are saying to themselves, I think we're good. It's been really tough, and their ideals and values have shifted. And I think it's just really important to remember that Canada, and I just want to mention this, similar to other Western countries, women develop their professional and educational paths often before entering motherhood, and childbearing is postponed. And so the more it's postponed, and this pandemic, which has just heightened so many of the challenges we have in terms of children and childbearing, it might have just postponed things a little bit more for people. And so either people have changed their values, they've changed their ideals, they've had a really difficult time in terms of disruption of their entire social networks, and are saying, you know what, I might not have that additional child right now, and that's okay for me.
That's just some of what we covered this week. You can find the full conversations on our website, tvo.org, our YouTube channel at youtube.com/theagenda, or our Twitter feed, twitter.com/theagenda.
The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.